and here we are at part 3. Again, if there are questions or concerns, definitely let me know. I'm hoping that the cases I give you over the next couple of days will be a little bit more helpful to see this and how it works clinically. In this part, we're going to be talking about a specific protozoal opportunistic infection, toxoplasmosis, but do know, again, there are a number of these conditions that are out there. We don't spend too much time talking about them in the original infectious disease lecture, but there is the chance to learn a little bit more about some of the other conditions that are out there, especially those on a tropical or a global scale next year, and it's going to be an elective. I think it's PHM 608. If there's questions, let me know, but that's a shameless plug because I teach that class as well. So we're going to be talking about toxoplasmosis, and this is the most common central nervous system infection in people who are not using appropriate prophylaxis. This does have a worldwide distribution. What's interesting about this one, though, is that immune-competent people can actually be infected with it as well. We see this quite often in pregnant women, even in the United States, and the impact on pregnant women and on their fetuses is pretty severe. So it's always good to know this one, not only if you are dealing just with HIV positive patients, but with pregnant women as well. This is an infection that is typically latent, and again, this one can persist for life. We see it typically in people who have a CD4 count that falls below 100 cells per microliter. The parasite will reactivate and cause disease, much like the reactivation of PCP. For illness to happen, several things must happen. So you have to consider that the CD4 count is almost always going to be less than approximately 100 cells per microliter. All people who are at risk for, or you have a concern that they may be having symptoms of toxoplasmosis, should be tested for their IgG to toxoplasma. That IgG has to be positive in almost every case, and so in exams and in cases, I would want you to know that if a person has a toxo IgG, you have to go based on that. If a person does not have one, you should be ordering one. And remember that from your previous classes in immunology, the IgM is for acute illness, and that isn't going to necessarily play a huge role in how we decide to treat our patients in this case. And they also have to not be receiving appropriate prophylaxis. That doesn't necessarily mean that they haven't been prescribed it, though that is important. We also have to consider that they may not be taking the drug appropriately, and we'll talk a little bit more about that as we go through. Epidemiologically speaking, 11% of people in the United States who are living with HIV have an IgG positivity for toxo. In other parts of the world, those numbers are much higher, and as examples, in Latin America, Africa, and Europe, the incidence rate is more than 80%. Approximately 300 cases were seen in the U.S. in the late 3,000 cases were seen in the U.S. in the late 2000s. Most commonly, this is seen in the central nervous system, but you can see it in other places as well. So when we talk about the conditions, at least for this class, know that when we talk about PCP, it's almost always going to be a lung infection. When we talk about toxo, it's always going to be an infection in the brain. Remember, this is almost always a reactivation of a dormant bug, so that IgM is not going to play too much of a role, but knowing that a person is IgG positive is very important. Cats are the only animals on the planet in which T. gondii can actually complete its reproductive cycle. So when other organisms get this, including mammals and birds, it can disseminate throughout their body and lie dormant, but it can't complete its life cycle. That does require that there is a feline in the area that can help it. So transmission usually involves ingestion of the oocysts. These oocysts can be found in soil and fresh water. So always make sure you're washing your hands after you garden or you've been playing out in the dirt, and drink tap water instead of the freshwater sources. This can also be found on fruits and vegetables which have been contaminated by the soil and water. So in most cases, if there's concern, you want to make sure you're washing them thoroughly and cooking them if possible before eating. And you have to consider that this is also found from eating the cysts inside infected animals. So if you're somebody who eats pig, cow, deer, other mammals, it's important to cook them to the appropriate internal temperature to make sure that you're killing the cysts. So you've probably all been to restaurants, though obviously not lately, with the consumer advisory right in the menu that eating raw or undercooked meats, poultry, seafood, shellfish, and eggs may increase your risk of some foodborne illnesses. One of the other things that this kind of plays a role in, outside of even foodborne illnesses, is toxo. So make sure that the meat is cooked to the appropriate internal temperature. And transmission can actually happen from human to human in two examples. One is vertical transmission, where the mother passes it on to her fetus. And the second is when somebody gets an organ transplant and the donor has toxo in their body. There are no routine labs that are specific for toxo, but the manifestations include headache, focal encephalopathy, fever, and confusion. The question that tends to come up is, what's the difference between focal and non-focal? The only difference is that one is specific to a specific area of the brain and the other isn't. So a focal encephalopathy is going to have an effect on one part of the brain, which may impact the type of symptoms that you deal with. One of the other things to keep in mind about this is that seizures are possible, and this could actually lead to stupor, coma, and death. I'm not sure how much I know about this Dr. Axe, but I did like this picture. A question that almost always comes up, even though we're pharmacists for humans first, is what are the symptoms in cats? And just a couple of examples of the symptoms that do happen in cats are listed there. What I will say about that is that generally speaking, those are going to happen in very young cats or in cats that have been living outside. An important thing about this slide too is a picture of the brain imaging. One of the things that we're going to see in almost all cases is that when somebody has concern about toxo and we do brain imaging, you're going to see what are called ring-enhancing lesions. The ring-enhancing lesions are seen here, here, and here. And they are exactly what they sound like. They're lesions that look almost like rings inside the brain. Those, if there was only one, it could actually be other things, but when there's multiple ring-enhancing lesions, it's a pretty good bet that it's probably toxoplasmosis. So how do you treat? Usually the therapy is started after a presumptive diagnosis, not a definitive one. Again, we don't want to go definitive because this involves biopsies. So presumptively, if the clinical manifestations are seen, plus we have those ring-enhancing lesions, plus they have a CD4 count that's less than 100, and they're toxo IgG positive, we are going to presumptively diagnose and we're going to start treating. The only way to definitively diagnose this is to find the organism in a brain biopsy, and obviously sticking needles into somebody's brain has its own associated morbidity and mortality. So we start to treat presumptively, and if after a couple of weeks the treatment doesn't necessarily seem to be working, or the imaging is starting to look maybe a little bit funny, we do need to consider alternative diagnoses. And as I said before, one example would be that if you only saw one single ring-enhancing lesion, there's a good consideration that that's central nervous system lymphoma, which is usually caused by Epstein-Barr virus. Preferred treatment is sulfadiazine and pyrimethamine. The doses are listed here for each of those. The only thing to keep in mind about this is that both are weight-based, based on the 60 kilogram cutoff, and I might ask you to know that. When you're dealing with this, we are going to add leucovorin to prevent some of the pyrimethamine-related adverse events. Pyrimethamine causes bone marrow suppression, which can cause some concerns hematologically. So we are adding leucovorin on board just to prevent some of those if we can. And in people who can't take oral therapy or who are severely ill, we will actually use the Bactrim again. Once they are able to take oral therapy, we're going to transition them back to the sulfadiazine and pyrimethamine. And all regimens are for at least 6 weeks. So whereas PCP was 21 days, this is 6 weeks. And I want you to think back to 2015, and most of you probably have not heard of this, but if you do remember the name Martin Shkreli, it's important to keep this name in mind as one of the reasons that people might have had issues getting or taking this medication before the pyrimethamine. He owned a company called Turing, which acquired the rights to the pyrimethamine, and he took the price from $13.50 a pill to over $750 a pill. And that meant that people who were taking this medication for the treatment of any sort of condition, but also toxoplasmosis, were paying upwards of $75,000 for a single course of therapy. Obviously, the world went crazy about this and condemned him for being a pretty horrible human being. His company actually changed the name to Phoenixis to try and get over some of the bad press. But they actually refused to drop the dose of the pill even after the bad press. So a couple of things that happened were that there was another company that started to make a combination capsule of pyrimethamine and leucovorin for less than $1 a pill. But most importantly, in the United States, the FDA finally approved a generic formulation of this in February of 2020. So 5 years later, we probably shouldn't see too much by way of issues with cost or trouble getting the medication. But for a good 5 years, we had a number of AIDS advocates and even human rights advocates complaining that this company was doing a very dastardly deed. So as alternatives for those who are unable to take sulfadiazine, we can offer IV clindamycin with pyrimethamine. In this case, clindamycin is 600 milligrams every 4 hours. If it's not a sulfa allergy, you can actually use the Bactrim twice a day. This is actually often used in resource-limited settings, and it seems quite effective, and it is less expensive. We haven't jumped on board as first line, but it is something to consider. Other options are atovaquone, pyrimethamine, and leucovorin, or atovaquone and sulfadiazine. In this case, we're dealing with a dose of 1,500 milligrams BID. So this is different than the dosing that we would see with atovaquone with PCP, either for treatment or prophylaxis. This is a higher dose. And then the question is, should we be using adjunct therapy? So when you're talking about things like focal encephalopathy, swelling in the brain, there is a consideration of potentially using corticosteroids. In this case, we're only using dexamethasone if there is a mass effect or there is any sort of edema related to focal brain lesions. We're using it for as low or as limited an amount of time as possible because we don't want to be causing immune suppression. And then the other question that comes up, well, what about seizures? Can we prophylax with anticonvulsants? The idea or the answer is no. But we do use these for people who have seizures. And the thing you have to consider about the anti-seizure medications is many of them do cause drug interactions. So finding one that doesn't, something like gabapentin or Keppra, is going to be a better idea than things like Dilantin or phenobarbital. So only when people have seizures do you use an anticonvulsant, and only when people have focal brain lesions that are causing swelling would you use a corticosteroid. Alternative drugs include sulfadiazine, pyrimethamine, and leucovorin. I am pretty sure that you haven't heard too much about these drugs, so I did want to go over some of the kind of key clinical pearls. Sulfadiazine, like the drugs we've talked about before in the sulfa class, can cause rash, fever, and GI upset. It can also crystallize out in the kidney tubules, causing some acute renal failure, and this can cause leukopenia as well. An important medical error that can occur and has occurred clinically, I've seen it at least twice in practice while I was working at ECMC in the dispensing pharmacy. There is another drug, sulfasalazine, which is used for some GI concerns. You'll learn about it more, I want to say, in 604 with Dr. Woodruff. It's dosed similarly, but it has no effect on toxo. So if you are dealing with somebody who's got pyrimethamine on board, leucovorin on board, and sulfasalazine on board, you know that that was a medical error. You should be calling the doctor to get that medication switched to the right drug, which is sulfadiazine. Pyrimethamine, the rate-limiting adverse event is hematologic. It's that bone marrow suppression we talked about before. And leucovorin does help manage some of those adverse events or prevent some of those adverse events, which is why it's added to the regimen. Leucovorin itself has no effect on the organism. It's just there to help the side effects of the pyrimethamine. And some interesting things about leucovorin, just so that we are all on the same page. Again, clinically speaking, You can see some old-time doctors that are still using the term folinic acid for leucovorin. That's not folic acid, so do be sure that you are not using folic acid to try and prevent the pyrimethamine-related adverse events. It does not work. When we're monitoring for therapy, we are assessing for clinical effectiveness. We would usually do daily neurologic exams, which are going to improve before the actual radiologic or the brain imaging would do. And then we do neuroimaging at about 2 to 3 weeks or sooner if there's no improvement in their daily neurologic exams. If at that case, we're not noticing any sort of benefit to treatment and the ring-enhancing lesions are still like they were before, that's when you'd start to consider that you have the wrong presumptive diagnosis and need to go on and try and find a different one. So secondary prophylaxis, what you do after you've treated for 6 weeks, you could use a couple of regimens. The most preferred is sulfadiazine, pyrimethamine, and leucovorin, though do notice that the doses are lower than those used for treatment. Alternatives are clindamycin, pyrimethamine, and leucovorin. This has no impact on PCP, or pneumocystis cerevisiae pneumonia. The one double strength daily of trimethoprim and sulfamethoxazole is usually used because this covers for both PCP and toxo. As an other alternative, you could use atovaquone with pyrimethamine and leucovorin or atovaquone with sulfadiazine. This does cover for both. And again, atovaquone monotherapy can cover for both, but there is a high rate of relapse for toxo. When you stop secondary prophylaxis is after the person's been on HIV medications and their CD4 count goes above 200 for at least 6 months. And primary prophylaxis for people who have a very low CD4 count and are toxo IgG positive, so they have to be toxo IgG positive, are going to be regimens like those listed below. So the ones that cover for both are the one double strength tablet of Bactrim. Dapsone plus pyrimethamine plus leucovorin is also going to cover for both. And like I said before, atovaquone covers for both, even though it is somewhat less effective. So do notice when we were talking about the PCP primary prophylaxis regimens, one of them was Dapsone. Dapsone by itself only covers PCP. To make sure that it covers for both, you have to add pyrimethamine, and because of the side effects of pyrimethamine, you have to add leucovorin as well. And when you discontinue primary prophylaxis is when the CD4 count goes above 200 for more than 3 months. And then the question that always comes up is, well, what do I do about my cat? So one of the concerns that everybody who is dealing with this deals with is, do I have to get rid of my cat? No, you do not. If you have a cat already, there is no sense getting worked up about trying to have to find a home for it or being upset that you're going to lose your pet. There is no need to get rid of the cat. How you would prevent transmission to yourself or other people is by having somebody else clean the litter box or making sure you are always washing your hands after you do so, even if you are wearing gloves. You don't want to get new kittens from those back alley shops, and it's best to get an older cat if you do get a new cat. Kittens tend to be most likely to have this condition. And you don't feed cats table scraps or let them outdoors. So there are a number of ways you could prevent getting it from your cat. But if you already have cats or you're looking to buy a cat, make sure you get an older one that's from a reputable source rather than one off the street.